How I'll share my screen, sir.
Sure.
Sir, I hope my screen is visible to all.
Screen is visible, but please make it full screen.
Yeah.
Yes, now it is perfect.
Perfect, sir.
You are
Very
clearly audible. Our screen is also visible.
Thank you so much, sir. Very good evening to all, and thank you, Team Melap, for the opportunity. Today, I'll be discussing a very important topic: diagnostic approach to poorly differentiated malignancies. We all know that the cancer of unknown primary site is a relatively common clinical entity. Within this category, tumors from many primary sites of varying biologies are represented. It accounts for 20 to 25% of the cups are actually poorly differentiated, and approximately out of these, 80% are having features of carcinoma and are termed as poorly differentiated carcinoma after the initial pathologic examination. And the remainder histologic examination results in the diagnosis of poorly differentiated neoplasm, signifying the inability to distinguish between carcinoma, melanoma, lymphoma, or sarcoma. So every attempt should be made to arrive at the most specific diagnosis as possible, since the treatment for various cancer in this group can be quite different. So, foremost important is the clinical evaluation. The evaluation of the patient with a cancer of unknown origin usually begins with a biopsy that documents the metastatic cancer. Optimum evaluation requires a number of clinical and pathologic studies. Once the diagnosis of malignancies has been established, the following procedure must fail to identify an anatomic primary site before the diagnosis of CUP can be made, such as history, physical examination, mammography, CT, MRI. The serum levels, the tumor markers like HCG, alpha fetoprotein, all these markers need not, won't be able to help us to delineate what is a specific primary site. Such cases are entitled for CUP. Further examination like positron emission tomography can identify a primary site in minority of the patients. Other traditional like serum tumor markers. However, these markers are often elevated and serial measurement may be useful in subsequently following the response to therapy. Now coming to our domain, that is a pathologic evaluation. The initial biopsy review. The first step in the pathologic evaluation of the patient with a poorly differentiated cup is review of the biopsy material. Non-specific light microscopic can be due to biopsy specimen that is very small or it is poorly preserved. Tissue obtained by fine needle aspiration provides inadequate diagnostic material, thereby limiting the ability to perform these special studies. Thus, examination of the poorly differentiated malignancies are using routine light microscopy alone is inadequate. There are no light microscopic features that can reliably distinguish between these different tumors or between the treatment sensitive and treatment resistant cancer. Even with a careful retrospective review of these cases, some tumors that are highly responsive to specific treatment regimen like germ cell lymphoma are not readily distinguished morphologically. Thus, we take help of additional evaluation. This includes the tumor biopsies from these patients should undergo additional pathologic evaluation using IHC. If the IHC results are inconclusive, we go ahead with the molecular cancer classifier assay. In the selected cases, electron microscopy and chromosomal analysis should be considered. If nothing comes to a definitive diagnosis and you feel the tissue is non-representative or is inadequate, a repeat biopsy is generally indicated if the tissue from the initial biopsy is insufficient. So coming to IHC, it is an important auxiliary method for the pathologist as it specifically visualizes distribution and amount of certain molecule in the tissue using a specific antigen-antibody reaction. Its unique feature is performed without destruction of the histologic architecture, and thus the assessment of an expression pattern of the molecule is possible in the context of the environment. A co-analysis of both target molecule and its subcellular, cellular, and intercellular relation is probably done best by the pathologist. The importance of this co-analysis is increasingly recognized by biomedical research fields such as prognostic and predictive biomarker investigations. A new concept of a companion diagnostic terminology has been introduced as IHC test, which is being performed on tissue. Here, the test results are directly associated with the targeted therapy for the patient. The companion diagnostic test belongs to the category of Class 3 medical device by FDA. We have HER2 testing, which was approved by FDA, and lately PD-L1 testing by Dako Agilent. This concept of companion diagnostic test has led to stringent monitoring of the test performances, especially for reproducibility of the results. The diagnostic accuracy has significantly improved because of the continuous discoveries of the tissue-specific biomarkers. So the advantages are, it is sensitive. The IHC techniques are very sensitive. It has improved over the years from immunofluorescence labeled antibody to labeled polymer-based system. Hybridoma technique has enabled production of wide range of highly specific monoclonal antibody. Many antibodies are available which identify different epitopes that overcome the effects of formalin fixation. The numbers of tests in the IHC are on increasing trend, and currently the departments associated with the cancer hospital, corporate laboratories are using more than 130 biomarkers for the same. It can be performed on different tissue and cell preparation, including your formalin-fixed paraffin-embedded sections, frozen sections, and cytology preparation. Slides can be reviewed as the end result with the chromatin substrate is permanent. The advantage of use of FFPE is that the antigen expression can be seen in the archival material and may be useful for the research purposes. So, in a nutshell, when you receive a biopsy, the review of the histomorphology is very important without clinical information. This should be our general practice for all medical students, especially the postgraduates. See the tissue, try and make your own diagnosis. Narrow down your diagnosis based on your first impression of the tissue. Then you should go ahead with the clinical information like age, sex, tumor location, prior malignancy is available or not. We reevaluate the histomorphology after receiving the primary information, and we formulate our top 1 to 3 possible diagnoses. So, tumor when defined lineage differentiation such as adenocarcinoma, you can use a broad spectrum antibodies like CK, CK7, CK20. For undifferentiated tumor, when there is no clear lineage, these are the tumor that we label as a poorly differentiated malignant neoplasm. So thus, determination of the tumor lineage here becomes very crucial. So the primary antibody, if you are very sure, or then you can use is the 4 markers, that is CK, S100, Vimentin, LCA. This will help you to narrow down to the lineage of the tumor. If it's CK, you're thinking about carcinoma. If it's Vimentin, you're thinking about sarcomas. If it is S100, okay, it could be melanoma, it could be nerve sheath tumors. If it is LC, definitely we're dealing with lymphoma. If it is CK and Vimentin both positive, then it should hit towards carcinosarcomas. Thus, the list of the antibodies are huge. If we want to characterize the immunohistochemical staining pattern in poorly differentiated malignancy, the most common you can use is CK, EMA, LCA, Desmin, Salfos, Synaptochromo. For carcinoma, as we have discussed, it is CK. For melanoma, you have Desmin, Vimentin. For sarcoma, you can have Vimentin as well as CK in some of the cases. Lymphomas, you'll have LCA. Neuroendocrine will be Synaptochromo. Germ cell tumor is Salfo. You can have combination of the markers, whereas for CK7 and CK20, when we think about this, most commonly we can think about the gastric adenocarcinoma, cholangio, pancreatic adeno. When it is CK7 and CK positive and CK20 is negative, the most common in female we think about is breast. In case of male, you think about lung adenocarcinomas. The list is huge. When it is CK7 negative, 20 positive, then it should head towards colon. Other tumors like Merkel and gastric adenocarcinoma also at times. When it is 7 and 20 negative, in male you have prostate. You might have in both male and female renal cell, hepatocellular carcinoma. Recently, squamous cell carcinomas have also been included. Thus, these are the tumor-specific markers and their staining pattern. We know what IHC needs to be applied. We know what diagnosis it will come to. But if you're not able to interpret the IHC properly, then you might misdiagnose something. For example, if you're using a beta catenin for fibromatosis, if it is nuclear, yes, it is fibromatosis. But if it is cytoplasmic, no, you're dealing with something else. This kind of an interpretation you need to know. Even if you have mastered the IHC patterns in different tumors, the staining pattern you need to acknowledge. Like for TTF1, it's going to be nuclear. For thyroglobulin, it's going to be cytoplasmic. Hepar, it's going to be cytoplasmic. For melan A, it's going to be cytoplasmic. CDX2 is going to be cytoplasmic. PSA is going to be cytoplasmic. So all these staining patterns are very important. So those list of carcinomas are huge. The staining pattern, these are some of which I have tried to explain in brief. I will not go to each and every tumors, but for example, small cell carcinoma, you have TTF1 positive with synaptochromo and high MIB1, that is approximately to 80 to 90%. For renal cell carcinoma, you'll have CK7, CK20 negative. No IHC staining pattern is completely specific. We need to be very sure. However, a specific diagnosis often suggested by the IHC results. We need not forget that the morphologic diagnosis is very important. IHC is just an aid that will help you to confirm your diagnosis, but you need to have a proper morphologically based your differential diagnosis to get a proper immunomarker presentation. These are the list of the tumors with their appropriate IHCs. I'm not going much in details with them. These are the markers for the epithelioid tumors. These are the markers for the small round cell tumors. So when you have a metastatic neck node in a middle age group person, and if it's a LCA negative, so the most common practice that we use is use pan-CK. If it turns out to be positive, then P63, then your differentials are narrowed down to basiloid squamous cell carcinoma or nasopharyngeal undifferentiated carcinoma. If it is P63 negative, that means you'll have to see for the adjacent tissues, like papillary thyroid carcinoma will be HbME1 and CK19 positive. Medullary will be calcitonin, chromogranin positive. Neuroendocrine is going to be chromo and synapto positive. If your pan-CK is negative and you have a metastatic tumor, then you have to go ahead with S100. If it's positive, it's melanoma. S100 positive, HMB45 negative, think about FBCS. If it is S100 negative, then you can think about something called rhabdomyosarcomas, in which your desmin, myogenin, and MyoD1 will be positive. When your IHC is inconclusive, you go ahead with the molecular cancer classifier or assays. Nowadays, the list is very huge. You have oncogene panels, you have 56 gene panel, you have 26 gene panel. Depending upon the symptoms, depending upon the diagnosis that you need, appropriate paneling can be asked for. For example, diagnostic gene expression profiling will help you to predict the tissue of the tumor of the origin in the patient with CUP. This technique is based on the detection of a site-specific gene expression, with some assay demonstrating an accuracy rate of approximately 80%. The molecular cancer classifier assay provide information that is distinct from the comprehensive molecular profiling. The role of MCCAs in the diagnosis and management of the patients with CUP is evolving, but most evidence suggests a benefit of site-specific therapy. Although data are limited, it appears to be valuable in the diagnosis of patients with the poorly differentiated neoplasms. As an example, in a group of 30 patients who retained the diagnosis after extensive IHC evaluation, MCCAs were predicted in the tumor lineage in 83% to be carcinoma, with 10 cases, sarcoma 8 cases, melanoma 5 cases, and lymphoma 2 cases. The specific site of origin were predicted for all 10 carcinoma in this particular article. The gene sequencing techniques have been used and are being useful in finding the actionable genetic alteration in the tumors of some CUP patients. We go ahead with electron microscopy, which is relatively expensive, and most commonly they're not being used only for the special tissue cases that are being used for electron microscopy. And these are probably your Cases like your polydifferentiated sarcomas, the presence of these structures such as neurosecretory granules in the neuroendocrine tumors and the pre-melanosomes in melanoma can help to identify these neoplasms. The undifferentiated tumors often lose these specific ultrastructural features as well as the typical histology. For this reason, the absence of a particular ultrastructural finding cannot be used to rule out a specific diagnosis. We come ahead with chromosome analysis, which we most commonly use in our clinical practice as well as in the pathological reports that we mentioned. So the utility of the cytogenetic analysis can be illustrated by the following. The majority of the B-cell lymphomas contains immunoglobulin gene rearrangements. A specific translocation like 1122 is found in your PNET, is also frequently now called as Ewing sarcoma. An isochromosome of the short arm of chromosome 12 can be detected in large percentage of your testicular and extragonadal germ cell tumor. NUT gene is associated with aggressiveness and it is easily analyzed through chromosome analysis. We also have NUT IHC antibodies nowadays. Detection of the Epstein-Barr virus genome can be indicator of nasopharyngeal carcinoma in patients with metastatic disease in cervical nodes and undetermined primary site. Thus, with these, I'll be explaining the application of some of the IHCs in our routine practice and how it helps you to approach to a poorly differentiated malignancies. One thing I would say, most of the people here are practicing in maybe in a corporate hospital, in a government setup, in an institute, but many of us are practicing in a standalone labs in which the onus of reporting is completely on you. Whenever you have a poorly differentiated malignant neoplasm with limited accessibility to IHCs or your molecular technique, don't be afraid to give a very broad report. In the sense, if you cannot delineate a report what it is, you may just call it malignant neoplasm and ask for a opinion from a higher center. If you have primary antibody and you have demarcated the lineage, you can just say it's a carcinoma, but what type, we don't know. So you can ask ahead for, evaluation in a higher center. All the more if there are junior pathologists who are practicing, and you should not be afraid to take a second opinion from your seniors, because this will not only help you to broaden your experience in reporting a case, it will also give you a confidence that you're going on a right track. Because if in case you're not taking a second opinion, you are doing IHC and IHC and you're not getting a report, you are actually depleting the tissue, which could be further used for some molecular study, which could have been used for some other testing, which could have narrowed down the diagnosis. So learn to stay and say no, and learn to know when to stop your reporting. That is very important. With this, I come with my interesting cases. I'll be sharing few of my cases. This was a 28-year male presented without significant comorbidity, presented with epigastric pain with jaundice since 1 month. A standard blood exam exhibited cholestasis with normal values of your hemoglobin, white blood cell, platelets, all your serum tumor markers being normal. We received an FNA. The FNA was very poor in cellularity. It was completely entrapped in the blood clot. We knew that it was some atypical cells. The guided FNAC was done from the pancreatic mass. I would like to tell you this. So definitely when you see these morphology, you think, okay, it could be an adenocarcinoma, it could be something. But since the morphology is so obscure and the patient was young, so we were little skeptical about giving a diagnosis of adenocarcinoma in the very scant cellularity. So we went ahead and we called it as a scant atypical cells, repeat FNA or biopsy correlation is advised. Based on the symptoms, a suspected diagnosis of pancreatic adenocarcinoma and a resectable mass, surgeon proceeded with a primary surgery without obtaining a preoperative sample. A curative Whipple pancreaticoduodenectomy with regional lymphadenectomy was performed with no specific preoperative discovery and an uneventful postoperative course. This was a Whipple's resection. It showed a single grayish white to brown solid tumor involving the head of the pancreas. Okay, coming with the histomorphology, what did we see? Similar cells that we saw on the FNA, these were monomorphic tumor cells composed of round cells lying discohesively in sheath, penetrating the pancreatic parenchyma. We performed initial panel of IHC. These were negative for CK, EMA, S100, Desmin, Synapto. Okay, so we're not dealing with the epithelial malignancy. What are we dealing with? Neuroendocrine? No. We went ahead with performing LCA. LCA turned out to be strong positive. But again, these were 320, PAX5, 138, ALK, CD30, all negative. What were we dealing with? We had no clue. We performed MPO, which turned out to be strongly positive, which was further added with CD117, which was further supported by CD34. It also showed positivity for 43, 68, with Ki67 being very high. So we were dealing with granulocytic sarcoma of pancreas. So extramedullary solid tumor mass composed of immature myeloid cells. These occurs in skin, soft tissue, lymph nodes, and bone. The differentials diagnosis lie between Burkitt's lymphoma, large cell lymphoma, and round cell, with median survival of 7 to 20 months. Radiation therapy or surgical resection is less effective. Chemotherapy on improving the disease-free interval or disease-free survival is essential. Thus, we have to emphasize being a pathologist, ROSE, that is rapid on-site evaluation, or pre-therapeutic biopsy should be the cornerstone for the diagnosis of pancreatic mass with atypical clinical presentation. With this, we come to the case 2. This was a 70-year-old gentleman who presented with an insidious onset of reddish, painless nodule all over his body, not associated with fever, weight loss for 3 months. These nodules were non-tender, not associated with any lymphadenopathy or organomegaly or any type B symptoms. CT scan showed chest and abdomen within normal limits. Hemoglobin and blood parameters were all within normal limits. CT scan of chest, abdo, and pelvis revealed no significant abnormality. The clinical impression for the clinician was maybe we're dealing with cutaneous lymphoma, or is it some soft tissue sarcoma? Excision biopsy of this nodule was performed. It revealed dermal presence of tumor, predominantly around the periadnexal and perivascular. These tumor cells were intermediate in size and showed irregular nuclear contour, conspicuous nucleoli, and moderate cytoplasm. Brisk mitotic figures were noted. Upon the IHCs, the tumor cells were strongly positive for LCA. These were further negative for your CD3, 8, and 7. Myeloid lineage, like we thought, like the earlier case, okay, it could be something with myeloid. MPO, CD117, all negative. B cell lineage, negative. Okay, so what were we dealing with? We attempted CK. CK was negative. Your rest of the marker like TIA, CD34, TDT, MUM1, TCR gamma, TCR beta, EBV, everything negative. We had no clue what we are dealing with, but it was something atypical lymphoid proliferation. We went ahead and we did HLA-DR. It was strong and diffuse positive. Okay. It was further positive for CD123. CD43 was diffuse, CD4 was diffuse, CD68 occasional histiocytes, MIB1 was around 40%. A diagnosis of blastic plasmacytoid dendritic cell neoplasm was thereby offered. The patient demonstrated a very good response with a complete disappearance of all the nodules by initial 2 weeks of therapy with a modified VFM ALL protocol and has completed 8 doses as of now. The patient has tolerated the protocol extremely well. Thus, we should know that BPDCN is a very rare malignancy of dendritic cell precursors, and it resembles to the normal counterpart of its expression profile. It remained an orphan disease for long until recently few series have been published with predominant cutaneous involvement, making it difficult to establish clinical, biological, and prognostic features. Extracutaneous involvement includes involvement of the bone marrow and the lymph nodes. Expression of CD123 is the main characteristic of PDCs. When in doubt, immunomarkers like TCL1 may be used to support the diagnosis. WHO of tumors of hematopoietic and lymphoid tissue has grouped PPDCN with category of AML and related precursor neoplasm, which has now been listed an own category, that is in 2016 revised version. This was the article that we published. case 3. This is a very interesting case in which a 48-year-old gentleman presented with a severe pain and breathing difficulty. Clinically, left parotid swelling was there with lymphadenopathy. A parotid biopsy was done elsewhere and it was reported as arsenic cell carcinoma. A PET-CT was performed and metabolically active heterogeneous lesions were seen involving the left parotid with infiltration of bilateral cervical nodes, axillary nodes, mediastinal, brain parenchymal lesion, etc. Here, since the diagnosis of arsenic was made, the clinician was very hopeful that these all are metastatic lesion of a primary salivary gland tumor. So, a fresh axillary lymph node biopsy was done, and we had received the nodal tissue. The entire tissue was taken up for processing. The histomorphology revealed the nodal tissue completely being replaced by the tumor cells, which were arranged in nest and glandular pattern. These show highly pleomorphic nuclei with prominent nucleoli with moderate cytoplasm. At placing hobnailing of the tumor cells were seen. This could very well be seen in majority of the tumors of salivary. So we were okay. We're dealing with some salivary gland tumors showing hobnailing with poorly differentiated. So we thought of arsenic being in transformation, or maybe we're dealing with salivary duct carcinoma. These were the thought process that we were having. Marked areas of necrosis were seen. Comedo-type necrosis was noted. Cytoplasmic vacuolation was seen. They had nice mucin positivity too. We went ahead and put the marker of CK7. We are happy to see CK7 positive, maybe a salivary gland metastasis. We could have stopped over there saying that it is in a known treated case. This is probably a metastatic arsenic. But we went ahead with confirming a diagnosis. GATA3 was strong positive. P63 was focal. CKIT was very badly positive in occasional cells. Not happy to see that. We went ahead and added dog1. 1 minute. Yeah. So CK20, CDX2, S100, SOX10, everything negative. Dog1 was positive in occasional cells. So we thought okay, probably it's a transformation. So maybe dog1 expression has gone, and we're dealing with a very high grade salivary gland tumor. AR was negative, so a salivary duct carcinoma was excluded. HER2 was also negative. So now we were stuck. What do we call it? Is it a salivary gland origin tumor to start with? We went ahead and put up the metastatic marker. It was strong and diffuse positive for TTF1 and napsin. So was it a salivary gland metastasis to parotid in the initial biopsy, which was reported elsewhere? We didn't know, but we had to give a diagnosis. We called it a metastatic adenocarcinoma with focal squamous trait since our P40 was focally positive and suggested site for primary lung. A series where calls were made are requested to the treating oncologist to get the salivary gland biopsy reviewed because we are not sure what we were dealing with, as it is essential to confirm/exclude the possibility of second primary. We got the biopsy of the salivary gland tissue after a period of 1 month. Here the course revealed similar tumor cells arranged in small nesting pattern at places showing discohesive sheathing. We could very well see the salivary gland. The tumor cells were more or less of similar morphology with active mitotic figures. At places, prominent hobnailing of the tumor cells were seen the way we saw it in our earlier axillary nodal biopsy. So we were okay, it's going to be a lung metastasis to parotid. We were happy to call it because nowhere the picture resembled like an arsenic cell carcinoma. We went ahead with CK7. It was positive, but we were shocked to see TTF1 napsin being negative. So what were we dealing with? Is it a second primary? They were negative for SOX10, S100, AR, HER2, P63. We added up for all your high-grade salivary gland carcinoma. Everything was negative. Dog1 also, the way we saw in axillary node occasional cells. GATA3 was positive. With this, with a heavy heart, we called it high-grade adenocarcinoma, NOS. Histomorphology and immunophenotyping favors a primary salivary gland origin over metastasis. So a double diagnosis of carcinoma lung and a salivary gland, which is rare, was offered. The patient is doing very well after the treatment. and all his lesions have been subsided. So, malignancy occurring in two different organs are relatively rare, and both presenting at the same time are even rarer. Synchronous and metachronous tumors often poses diagnostic challenge. The diagnosis of multiple primary tumor is now increasing due to an increased awareness of possibility of a second malignancy. The higher use and sensitivity of diagnostic methods, as well as that of the recent improvement in cancer treatment and survival, will further lead to higher prevalence of multiple cancer. Thereby, high index of suspicion is very necessary. A thorough knowledge about the principle and practice of IHC is essential. Imaging techniques and conventional morphology alone may be often inadequate to obtain the reliable diagnosis. Appropriate immunomarkers and molecular testing needs to be used. Thus, we should know that IHC aids in confirming the diagnosis, but nothing beats the basic and the morphological approach. With this, I come to my case 3. This is a 2-year-old male presented with a huge sinonasal mass. On scan, a large multilobulated soft tissue mass was centered in the nasal cavity with extension to the anterior and the middle cranial fossa, cavernous sinus, left orbit, and the gross mass effect in the displacement of the ipsilateral eyeball, supralaterally with deviation of the nasal septum. Possible involvement of the hard and soft palate, most likely suggestive of aggressive neoplasm. This patient was offered a diagnosis of rhabdomyosarcoma somewhere in the interior, and a chemo was already started. We had received the blocks which were given earlier, which were labeled as rhabdomyosarcoma for second opinion. Upon the HA, it revealed a very aggressive looking high-grade tumor arranged in sheet, nesting, and places showing some form of cystic change. The tumor cells were highly pleomorphic with prominent to inconspicuous nucleoli, moderate amount of cytoplasm. Since it was called rhabdomyosarcoma, we put up the initial panel of carcinoma as well as for rhabdo, since we never thought about rhabdo, so we wanted to be very sure. So CK and EMA were put together. CK was positive, EMA negative, and Desmin negative. We need to be very sure when you're dealing with carcinomas. When you're confused, it's a carcinoma, lymphoma, or sarcoma, try and put both the panel, that's CK and EMA. It will help you to confirm your lineage. So we thought, okay, CK is diffuse strong, it might be epithelial, but EMA is negative. So we were a little cautious with this case. We went ahead and put up an extensive neuroendocrine markers, 56 being focal positive, rest all markers being negative. We add up all the other markers since the clinician was like, madam, we have started chemotherapy on the basis of rhabdomyosarcoma. So we added up myogenin, MyoD1, S100, P63, LCA, CD30, GFAP. Everything turned out to be negative. Only marker that is CK positive. In a 2-year-old kid whose one eye was already fired, we didn't know what else to do. So we added a SALFO, which turned out to be strong diffuse positive. 30 was negative, so only thing glypican-3 was left, which again turned out to be strong positive. A final diagnosis of malignant germ cell tumor with predominance of yolk sac tumor component involving the sinovital region was made. A comment was stated to correlate with serum LDH and AFP level, which was markedly raised. I ended up calling the clinician, what is the state of the patient? He was like, madam, la jawab response hai. And though his one eye was fired, the patient is doing extremely well now. Thus, we should always remember entity called extragonadal germ cell tumor of head and neck region, which accounts for at 5% of all the malignant GCTs. Orbit is a very uncommon site for occurrence of extragonadal germ cell tumor. Pure yolk sac tumor of sinoorbital region is a rare neoplasm with only a few cases being reported in the literature. It is known that germ cells migrate through midline, dorsal mesentery before reaching the gonadal ridge. Therefore, remnant of the cells along with the migration path can lead to the germ cell tumor. Undifferentiated round cell tumors in head and neck region have a very long list of differential diagnoses like rhabdomyosarcoma, pseudotumor, lymphoma, LCH. Awareness of this entity is very important as this is an aggressive tumor with a very definitive treatment. We come with the case 4. This was an interesting case in which a 62-year-old female post-thyroidectomy presented with a swelling in the neck. Total thyroidectomy was done in 2020. A biopsy opinion of adenomatous nodule with extensive infarction suggestive of renal thyroiditis was offered. Now she presented with right supraclavicular swelling, and we received the 5-paraffin blocks. It revealed a spindle cell neoplasm arranged in fascicular and vague storiform pattern. Breast mitotic figures were seen with moderately pleomorphic nuclei. Immunostain were added. These were positive for S100 focally, Soxtin focally. They were negative for CK, CK5/6, HMB, Paxate, Synapto, 34, ALK, CDK4, MDM2, all your spindle cell marker which were added up negative. Paxate we thought could be because thyroid was operated, could be a spindle cell lesion of thyroid. CK5/6 CK, we thought probably it's a spindle cell, squamous cell carcinoma. Everything turned out to be negative. Only focal positive Soxtin and S100. We didn't know what we were dealing with. P63 again, occasional focal. Okay, our CK was negative. So we thought, okay, could be loss of expression. SMA turned out to be diffusely positive. MEB1 also very high. EMA was diffusely positive. So we knew we were dealing with some carcinoma over here. CD10 strong diffuse positive, and calponin was added up, which showed occasional cell positive. So we came to a diagnosis of spindle cell myoepithelial carcinoma, which suggested likely site of primary being salivary gland / soft tissue. Here again, we asked them to review the thyroidectomy slides. Post-thyroidectomy slides were retried. We didn't get the blocks, but the slides we were able to get it. What we could see, the thyroid parenchyma were infiltrated by plasmacytoid-looking tumor cells at places showing spinduloid differentiation, as we saw right now, thereby confirming a diagnosis of myoepithelial carcinoma. So these are the rare tumors and they mimic other tumors. So we need to keep this entity very much in our mind. Currently accepted diagnostic criteria of myoepithelial includes morphologic and IHC and a clear-cut tumor infiltration into the adjacent salivary gland or other tissue. Here we did not get any salivary gland tissue, but when we asked the clinician, he was like, ma'am, probably it must have arisen from a minor salivary gland. Assessment of the invasion is usually difficult in tumors arising within the minor salivary gland, and this requires adequate sampling of the tumor host tissue. The treatment of myoepithelial carcinoma has been mainly surgical, including wide excision with free margin with or without nodal dissection. The role of chemotherapy and radiotherapy has not yet been established. This is a beautiful article in which they have highlighted how do you delineate your myoepithelial carcinoma when they are poorly differentiated. If time permits, sir, can I go ahead with 2 more cases or should I pause over here? Neeraj, sir? Okay, they may not be there. Coming to this case 5, this was a 27-year-old female who presented with amenorrhea for 6 months with a subsequently developing lump in the left breast. Clinical impression was malignant phyllodes, obviously, query IDC. Outside FNA, somewhere in the remote area was offered as fibroadenoma. The tumor cells here also were arranged in fascicular pattern. We did not see any leaf-like pattern over here. It was a high-grade spindle cell tumor with pleomorphic nuclei. CK was negative. It was highlighting the entrapped benign ductal cells. CK5/6 also similarly. These were negative for P63, P40, Soxtin, S100, ER, PR, SMA. CD34 highlighted the blood vessels. These were positive for Desmin. Okay, so we added with the normal protocol myogenin, which showed nice positivity. MyoD1 again showing nice positivity. MEB1 was on the higher side. A malignant spindle cell tumor was offered with the differential diagnosis stating that malignant phyllodes with a heterologous element and a primary spindle cell rhabdomyosarcoma of breast. and a more section needs to be examined. We need to remember that breast sarcomas form a very small percentage of all the malignancies. Rhabdomyosarcomas are more common in the children as compared to that of the adults. Chemotherapy and the radiotherapy have an uncertain role in improving the disease survival. Histopathological examination and IHC stains plays a very significant role in making the diagnosis. With this, I'll come to my last case. This was a 29-year-old female present with a pain in abdomen. A pancreatic mass along with a splenectomy was done. This showed a well-encapsulated bosselated appearance with hemorrhagic fluid drained out. Histomorphologically, the pancreatic parenchyma were infiltrated again with the similar-looking cells. These were sheets of small round blue cells with hyperchromatic and scant cytoplasm with brisk mitotic figures at places showing hemangiopericytomatous pattern. Areas of comedotype necrosis were also seen. Looking at the image, we thought probably it's a neuroendocrine tumor. It was nicely infiltrating your pancreatic acini. So whether it's a neuroendocrine carcinoma or polydifferentiated carcinoma, these were the two differentials that we had in our mind. We added up CK, which was negative. CK7, again negative. We were not happy to see that. Synapto was blush-like positive. Again, chromo was negative. CD56, occasional cells. What were we dealing with? We thought whether it's again a granulocytic sarcoma, neuroendocrine, PDC, we don't know. Then we added EMA. Again was negative. So we didn't know whether, since synapto was positive, we thought if EMA comes out, we might call it a polydifferentiated neuroendocrine. But again, it's a negative. LCA, CD30, both being negative. We were absolutely clueless what we were dealing with over here. Negative for 1920 c-kit. Beta-catenin also cytoplasmic. We added a pimentin, which was nice and strong positive, which was further positive with MYC2 and NKX 2.2. Thus, we gave a final impression of malignant tumor involving the tail of pancreas, a close possible diagnosis of Ewing sarcoma / PNET. Correlation with cytogenic study is essential. This showed nice positivity for 8SWR1 gene rearrangement, thereby confirming the diagnosis of pancreatic Ewing sarcoma, which is an aggressive malignant tumor with an unavoidable recurrences. 25 cases have been reported so far in the literature and age range between 2 to 60. The most common symptoms are abdominal pain, jaundice. A differential diagnosis here includes DSRCT, small cell neuroendocrine carcinoma, and pancreaticoblastoma. Improvements in the detection of PNETs and their early surgical removal has had a significant impact on the survival rate of these patients. From the literature, it has been observed that patients treated with surgery combined with chemotherapy were alive after 5 years of treatment in the 80% individual. So with this, we come to our conclusion. We are in a new era of personalized medicine, even for the diagnosis of CUP. Diligent selection of IHC panel and careful evaluation is a key to the diagnosis. In addition to the number of IHC marker, molecular tests are commercially made available to determine the tissue of origin. A molecular tool not only identifies the site of origin, but are claimed to identify the molecular substance of CUP, which would require specific or targeted therapy. These sophisticated tests needs to undergo validation studies before being employed in the routine practice. At present, we have to deal with the CUP menace with carefully constructed IHC panel and get geared up for application of molecular tests in the future. Thus, application of IHC in the diagnosis and classification of undifferentiated neoplasm has become an indispensable ancillary study and is crucial in oncology pathology. The diagnostic accuracy has continuously improved in recent years because of the discovery of additional tissue-specific biomarkers. Interpretation of IHC needs to be carefully planned. A consideration of stabilizing inter-observer consistency and objectifying interpretation of IHC result is crucial. We need to know that diagnosis improves with experience, and collaboration across the specialty will help us to give the best possible diagnosis. These are my references. Sincere thank you. I'll be happy to answer if somebody has any questions.